Okay, it started. Okay, cool. Go back to share. Hey, so did you guys get it? Did you guys watch the video I sent out?
Yeah, the YouTube one.
Yeah.
I had time. Yeah.
I definitely did not watch it, but I
Watch it. So check it out and get a
All
chance.
right.
But I'm gonna try and spend 5 minutes before each one of these things sending out a video like that. So what I want to do is that video I think really describes what we're trying to do as a company. It really focuses on the what that video focuses on is the company. So in other words, what it was, Jesse, it's a video. So this guy, he's like I see a lot of his stuff, but he's like a motivational speaker, and he speaks a lot to companies and stuff like that. And you would like it because he talks a lot about Milton Friedman and different types of economics people that I would imagine you're into that stuff, but maybe not. But like that talk about capitalism versus communism and the benefits of this society versus that society. But he talks about corporations and how you have a lot of corporations that just think of the short term, but really what a good corporation will do is think about the long term. I want to be around for forever. I want to be around for a long time. um, so he talks about importance of corporations making decisions not just based on what will make money, and talks a big thing that he talks about, or one of the things he mentions that I want to focus on, was the importance of a corporation developing future leaders. And so Christina's coming in too. I think that's Christina. So talks about the importance of corporations, developing future leaders, and how they, it's something that if you want to be a company that outlives yourself, that's something that you would want to do. And so what I would like to do is develop you guys to be future leaders, especially the younger people, like Joe, who's just starting out as in your career. I think that's something we don't focus on enough. We focus on a lot the medicine aspect of things, but we don't focus on the important your ability to succeed is not just going to be how much you know in medicine, but how well you can lead, how well you can interact with others, how well you can direct others. So the video itself focuses on the organization and what the organization should do. What I want to focus on in the future is what you guys can do from the bottom to act as leaders and to work as a team and to make the whole company itself better because you're better, right? And so I'm gonna I encourage you to watch it. It's not my strength as far as it's not a topic that I am good at talking about, so I'll fumble through it a bit. But and we can, if anybody watched it has anything they want to bring up, I'd encourage you to do it now. But I also just would like you guys to watch those things because I think it gives a good um, impression of what this company wants to be and what we want to do. And I think also that if we implement some of these policies, we'll all be better as a whole and we'll all grow as a whole. So watch it. Does anybody did Joe, I think that's Christina, did you all watch that or what'd you think about it?
Yeah, I thought it was a pretty cool video. They talked about like, are you a finite person or infinite
Yeah.
person? And just like kind of what legacy you leave behind. So I thought it was a good message.
Christina, are you there?
I haven't watched it yet.
Yeah.
I've been in dad hell, but I will watch it
Yeah,
after
it's
this
it's
meeting.
fine. And if you guys, it's up to you. If you
Hi,
watch it,
Anderson.
yeah, if you watch it, great. If you
Hey,
don't, yeah. If you watch it, great. If you don't, you don't. But again, I would encourage you to do it because I do think it's one of the things that we forget. What we often forget in medicine too, that we focus on the client, not just the dog or not just the animal that's in front of us. So we're going to talk about the medicine, but there's a lot of other things you need to consider. And no doctor is good just by knowing medicine, right? A doctor's only as good as their team. And so if your team if you interact well with your team and you do well with your team, you're going to do a much better job, even if you don't know your medicine very strong, than if you have a bad relationship with your team. And if your team it feels like they can trust you and they feel like you want to make them a better leader, and that's what we should do as a company, then everybody's going to benefit at the end. Okay, I'm going to share this screen and then we'll start this presentation. This is a good one. So this is one that I think it's a pretty good presentation, but maybe I'm wrong. But this
Wait,
one
is
is
this
one
is
that
this
I
only for
actually.
doctors?
What's that?
Is this only for doctors? Where's everyone else?
No, they don't show. All the half the doctors aren't here, but it's for everybody. This is
Oh,
for
okay.
everybody.
All
So
right. All
no,
right. I'm gonna mute myself now. All right.
you can come in at any level. And we can do again. This will be good for everybody. And when I talk about leadership too, I'm not just talking about the doctor level. And Jesse, I don't know if you realize, but I put you on a few charge things this month, a couple of open slots that were there. So I'm not
All
talking
right.
not talking just about the doctors. I'm talking about technicians as well. And again, as technicians, you guys will step up into leadership positions, and that's going to help you advance in your careers, help you advance in life. And it's an important trait to develop. Okay,
Dana,
so what this talk is going to be
I
about
hope
is
y'all did not just hear my husband say that.
I didn't hear anything. So what's you so what this talk is a talk that I actually gave in the military to some captains that are veterinarians. And they are often, doing a lot of general practice stuff. And so they're in the process of, learning how to do, some of this more critical care type stuff. And I think it'll be a good, it'll be good especially for Joe to walk through some of this. This talk not only is about the actual blood transfusion and the what how you give a blood transfusion and different things to think about the blood transfusion and rat poisons, but it also walks us through the case and working it up. And so that's the part I think that's going to help you the most. And I have a few of them like this that I'm going to give to you, Joe. And I think they'll help you when you come across some of these emergency situations. So this is Daisy. She's an 8-year-old spayed female golden retriever. I said she's a DoD sent dog because again, it was a military talk. She could be anything. History is she is acutely down, not walking. And this is just a kind of the quick history that the owners gave us. So when something comes in the door on emergency, we want to always pretty much triage that thing pretty much immediately. And so we have trained our technicians that I've worked at some places where the front desk determines what things get triaged. We decided everything gets triaged, right? And that's what I was taught in my residency, and that's what they do in human hospitals. And so I just transferred that down to our hospital. And typically, when you triage something, you just want to get a brief history of, hey, why are you here? There's certain key things you might want to look for in that history that would spur you to do things a bit quicker, right? Does it have a history of a toxin? Is it a Great Dane that is coughing and gagging? Those are things that you would want to jump on a little bit sooner. And then you just want to get a quick primary survey, heart, brain, and lungs, right? Is everything good with the heart, brain, and lungs? And if everything is good there, and there's nothing in that little brief history that spurs you to be concerned, you can let that case wait. But if there's something in that brief history or that primary survey that concerns you, and the technician or whoever notifies you that, hey, I think this is a problem, then you have to deal with that one more immediately, right? So, the concept of a primary survey and your secondary survey. Primary survey, just getting the initial information to determine if you need to see this one sooner rather than later. And then the secondary survey, we find out all the additional rest of the information. Is it up to date on vaccines and good stuff like that, right? So again, this brief history, this dog is acutely down. It's not walking. It has a temperature of 100 Fahrenheit. It has a pulse that is 180 and weak. It's the pulse is quality. It's a respiratory rate 60 with no effort. It has pale mucous membranes. Its CRT is 2 seconds, and its weight is 20 kilograms. So when you look at this, what are your problems You know, what are our problems that we have here in this list?
Okay, first things first.
Well, the pulse and the heart rate.
Yeah.
Pulse I
Number
don't like,
one.
right? That pulse is a 180 and it's weak, right? What else you got?
That refill time of 2 seconds.
Now, refill time's not good. Refill time's 2 seconds, right? Dog is
Blood
acutely
pressure.
down. It's lethargic, right? So we got a dog that's lethargic. We got a dog that has a pulse of 180 with a weak pulse quality. It has a CRT of 2 seconds, and it has a respiratory rate of 60, which is a little bit on the high side, not extremely bad. There's no effort to it, right? So, you know, again, I look at my problems. It's a little tachycardic. It has an increased respiratory rate. It has pale mucous membranes with a bit of a prolongation at CRT, and it has weak pulses, right? So which of these problems would you say are, you know, there's two of them I'd say that are a good, solid, like, that's a problem. And one really, I would say that is a good, solid, objective problem. In other words, what I mean by that is that have you ever looked at a cat and you say, this cat looks pale, and then you check a PCV and it's fine?
Yes.
The
Yes,
cat's in
right?
shock.
Or have you ever felt a cat's pulses and said, I think they're weak, and you check the blood pressure and the blood pressure's fine? Yeah, so I mean, sometimes, especially if it's a fat cat, right? So, which of these problems do you think, like, if I see it, I know it's real?
The
Pale
tachycardia.
mucous membranes and
Yeah, that
tachycardia.
tachycardia, right? That tachycardia, and that's a good tachycardia. That's just not mildly tachycardic, right? In a big dog, you know, that's 180. That's a real problem. I'm gonna really focus down on that problem, right? So, you know, I'm gonna say that tachycardia is real. And then what I like to do, and we do this every day, but I don't like to, you know, I can say tachycardia. Tachycardia has the differentials of it could be an arrhythmia, could have been exposed to a toxin. It could be that the animal is in shock and has a low blood pressure and has a compensatory response to that. It could be that the animal's hypoxic and it's a response to hypoxia, right? It could be, those would probably be my main big ones, I would say. You know, it's arrhythmia, shock, hypoxia, stress. Could be stress. That would be another one. So there's about 5 of them there, right? So about 5 differentials I could have for that tachycardia. But if I group that with weak pulses, prolonged CRT, and pale mucous membranes in a dog that's dull, does one of those differentials stand out?
Okay, I would do an ECG to rule out a bad rhythm because that 180 weak pulses. But that dog probably has a hema-abdomen. He's bleeding.
So
So
yes, so
shocky.
that's an interesting concept you say right there. But yes, you could have, you know, a heart rate of 180 causing weak pulses, but typically, you know, in a dog, even, you know, the heart rate of 180 is high, but it's not like a 240 or something like that, where it causes the heart to beat so fast that it's constantly contracted, that it doesn't get any forward flow out of there. There's not a lot. You know, they usually can get pretty good flow, even a VPC, like a VTAC at 180, we don't get too excited about, right? So, you know, I would say that, you know, not to say that an arrhythmia can't cause weak pulses, prolonged CRT, pale mucous membranes, dull, you know, it can cause shock, in other words, right? But this dog, to me, you know, like Jesse said, it looks like it's in shock. And I used to work with this uh, mentor of mine, and something would come into the door, and she would be like, it has this. And I'd be like, okay. And then I'd work it up, and then it was a hemoadmin. Or she'd be like, oh, that dog has this. And I'd look at it and, oh, it's a disc dog, right? So as we go through our careers, something will walk through the door and we just tend to automatically know what it is. But we don't know what that dog is just on tachycardia. We know what that dog is because it has tachycardia, weak pulses, prolonged CRT, pale mucous membranes, it's dull, and it's a golden retriever that's old, right? And so we know that they get hemoabdomens, right? Like that's one of the things that they get. So yes, if I saw this dog walk in, 8-year-old golden retriever with this clinical picture here, I would immediately that equation to me would equal a hemoabdomen, right? It's not always the case. We'll find out with this dog, it's not exactly that, but that would be my typical, scenario, right? So when I get into my car and the gas tank is empty, right? I know, oh, well, I haven't filled up with gas in 5 days. I'm out of gas. I got to go to the gas station, right? But how do I know I don't have a hole in the gas tank? I don't know that my gas gauge is broken, right? Well, if I got into my car and I filled up with gas yesterday, well, maybe there's a hole in my tank. Maybe someone stole my gas. Maybe my gas gauge is broken, right? So when I look at a problem like tachycardia, I don't just look at the tachycardia. I look at the situation surrounding it, right? So what I'm trying to accomplish here, what I'm trying to relay here is that when we're working up these cases, we're taught in school to problem differentialist, problem differentialist, problem differentialist, right? But try to relate your problems together, and if you have, tachycardia on that list is shock, weak pulses, that's always shock, right? Prolonged CRT, well, that could be shock, that could be, vasoconstriction because they're cold or, they're stressed, right? Pelvic mucous membranes, that can be shock, that can be pelvic mucous membranes because they're stressed. Dull, that can be so many things, but shock is one of them, right? So when I look at this tachycardia, shock is on every single list. So one of the ways is you can write out differentials for each one of those, but you can also group them and say, well, tachycardia, has these differentials, but if I have these other things going on, this differential stands out more, and shock is it, right? So I would say, my working diagnosis right now is that this dog is in shock, right? And then, what kind of shock it is, I don't know that yet. I'm gonna be worried about hemorrhagic shock or hypovolemic shock, but that remains to be seen. So what would you want to do? You have this dog walk in your door, you haven't really talked to the owners that much yet. They don't, they haven't really signed any estimates or anything yet. So what do you want to do? Jesse said one of them, let's get an ECG. We said arrhythmia is on the list. We can rule that out real quickly. This with getting an ECG, right? What else could we do? That's just real simple, easy to do. Things that I made. What's that?
The easy four, that
The
PCB,
easy
total
four, the big
solids,
four, the
blood
quats,
glucose.
the minimum database,
Okay.
whatever you want to call it, but
Yep.
PCB solids, glucose, and azo, right? Or now we replace it with lactate. But just kind of get some basic values that can tell you about, if the animal's in shock, if the animal has a low glucose, that things that you might need to address immediately if it's anemic or has low glucose, or things that can even give you a rough idea of liver and kidney function, right? When we had the azo on there, if I had that azo that was out of range, say a cat came in, it was really, had a really prolonged skin tint, small kidneys, the azo stick was out of range, the PCB was a little low, the total solids was high, and the glucose was normal or elevated, what did that cat have? Skinny cat, old
Say that.
cat,
Say that again.
skinny old cat comes in with a prolonged, really prolonged skin tint, small kidneys. Azo is your BUN essentially, right? And it comes in out, it comes in like
CKD. Yeah.
CKD, right? That's a
End stage.
CKD
Yeah.
cat. Yep, and I can diagnose that for an exam, and in our place we don't even charge for the quats, right? So you can diagnose that for $200, and you can tell that owners this is not good, right? If I had a little puppy come in that's neurologically inappropriate, it has a decreased total solids, a decreased glucose, mildly low PCV, but not too bad, and its azo is low at the lowest 5 to 15. What does that puppy potentially have?
I'm thinking a shunt.
A shunt, right? Yep, because that's your all your functional factors of your liver are down, and that's what Scott always harps on. Oh, look at this, the cholesterol's low and the albumin's low and this, right? So and those can be useful, and the shunt dog will have those all being decreased. A lot of times they don't have elevated liver enzymes. Sometimes they do, but a lot of times they don't. So I think a quats or a big four or minimum database or whatever you want to call it, easy four, those are all good things to do, and don't cost you any money. I purposely made them that way so you can do an exam and you can do a fast scan and you can do those tests, and you don't even have to get really much permission from the owner to do it. You might want to let them know you're going to get a blood sample, but you don't have to stress out about the cost of it, right? It's just the permission to do it. So, you might want to put in an IV catheter right away. We do have, critical care forms that owners can sign and gives us permission to spend about $1,000. But, I would probably consider putting a catheter in this dog. No, it looks like it's going to be in the hospital. In other words, sometimes just asking the owner's permission, I find, helps get them in that mindset of, oh shit, my dog is really sick, because a lot of times they don't realize how sick the animal is. So if you start asking to put in an IV catheter, it gets them to start thinking before you get in there. We could do electrolytes and lactate, ECG. We have all that on there. Blood pressure. Did I put that one on there? Yeah, blood pressure I did. So we got blood pressure here, right? But so PCV, let's just go through some of these. PCV solids, glucose, azo, it's 42%, 4.5 on your total solids, 89 on your glucose, and 5 to 15 on your azo stick. Azo will give you like, and we have them there. It'll give you like 5 to 15, 15 to 26, 30 to 40, or greater than 50. Shut up, Siri. Siri's talking to him. So it looks like your PCV is pretty good. Your solids is a little low. Your blood glucose is good, and your azo stick is good. So then we talked about what these tell us already. They give us a rough idea of liver function, kidney function. Could this dog, its PCV is good. It's 42%. Could this dog still be bleeding? I ask this question all the time. You'll probably hear it from me multiple times in the future as we go through more and more of these.
Yes.
Yes, it could be. So, if I have a cup of blood and I check the PCV and solids on it and it's 50 and 5, and then I pour the cup of blood, half of it out, and now I have half a cup of blood, and I recheck the PCV and solids, it's still 50 and 5, right? Because I pulled out the same amount of fluid as I did red blood cells. So I didn't change the concentration of my total solids, and I did not change the, percentage of my red blood cells. Now, if I have a spleen that contracts and fluid moving into the intravascular space from the interstitial space or intracellular space, right? Because my dog is bleeding, right? Then I'm going to maintain that PCV, and my solids is going to drop, much like this dog looks like it's doing. And then as I lose more and more blood and I give him fluids, I'm going to see both those numbers starting to drop. So a lot of times what we see in a bleeding dog at first is the solids drops, and then later the PCV drops. So whenever I see that and I suspect bleeding, that gives me, greater confirmation that, oh, maybe my shock is due to hemorrhage, and that's the cause of low solids. Now that low solids could be due to, GI loss. It could be due to renal loss. It could be due to liver disease, but, that's going to give me a little more suspicion. We try to do electrolytes. We don't have a cartridge. We have a lactate. It's 5.3. So what does this lactate tell us?
That there's
That's not good.
That's not good. That's exactly what it tells us. It's an indicator of badness, is what some people will tell you, right? And so it's elevated. Now we used to say, okay, lactate's high. That means cells are running under anaerobic metabolism, and so that means the dog is in shock. And that is true. They can be, running under anaerobic metabolism because the cells aren't getting enough oxygen, whether it be due to decreased perfusion, whether it be due to hypoxia. And so the cells are producing more lactate, and your lactate goes up. We call that a type A lactic acidosis. And that's often the reason lactate is high. But there are things that can happen, like sepsis and cancers and use of certain drugs, that can shift you to an increase in lactate production. So it is not always an oxygen delivery problem. It sometimes is other, things like sepsis, where oxygen delivery is fine, but your shift to lactate, goes up. And so it's more of a, it could be an indicator of poor perfusion. It could be an indicator that you need fluids, but it's not always an indicator that you need fluids. And sometimes there's, what they call type B lactic acidosis, where you're just being shifted to, producing more lactate in your body for various reasons. And cancers, I know, is a big one. Certain drugs are a big one. Sepsis is a big one. Or SIRS is a big one as well too.
I got a question for you about lactate. So you may have answered it, and it may have just gone over my head, but I noticed that some doctors, not like at this location, just like in my years, have done like serial lactates to kind of like they're like, oh, it's a 5.3. Let's start some fluids. and then they'll kind of just check the lactate as it goes. I've heard arguments that like doing those serial lactates are not like truly worth it or diagnostic of like the total outcome or like the prognosis of the outcome. Like, can you explain a little bit more about that, or if you like them, or is it case by case type of situation, or what's up with that?
Yeah. So their serial lactates theoretically are going to be a better, way to evaluate lactate, in my opinion. And I'll take that back in a second. But if I'm going to use lactate, like there was a study out there that they looked at dogs with GDV. And they said if they have a lactate greater than 6, they have an increased risk of gastric necrosis. And so now you see a lot of people, if the lactate is high, they'll greater than 6, they'll tell the owners, hey, this may not be good. You have a greater chance of gastric necrosis. The dog may not do well. And I think if they had a lactate greater than 11, they all pretty much died or something like that. Or they had a greater chance of death at least. What they found was that, oh yeah, that's the single indicator is pretty good, but really what tells you is if they have a lactate of 6 and then you can't get it back down, that will really tell you that things are bad. So, if they start out with a lactate of 6 and then recheck it again and it's still staying at 6, or it's going up to 7, that is definitely an indicator that things are worse. And that's just common sense, right? If you can get that number to improve, then that seems like they would do better. And if you can't get it to improve, well, that's obvious that they're not going to do as well. But a lot of people will say that, a persistently elevated lactate is really what you have to look at, if you're going to make life and death decisions on this dog. Do you go to surgery? Do you not go to surgery? Like what direction you're going to go in? So you can increase, I would say, your ability to predict things with lactate by using serial lactates versus just a single lactate. I do find that while I like lactate and lactate's pretty good, most of the time I don't need the lactate to tell me things are bad. And what made me start switching away from using lactate a lot was that we don't do this at our facility, but at other facilities, they're going to make the client pay like $50 every time you run a lactate. And I was like, you know what? This test is not worth $50. So I usually could say, oh, the blood pressure's still low or their heart rate's still high, and I can get a good idea, if things were bad or not just by looking at the animal. But sometimes I have had a few like IMHA cases and stuff like that where I think they're doing okay. And we would run a quats in the morning, which included the lactate and instead of the azo, and it'd be like a little bit high, like 4 or 5. I'm like, something's not right with this dog. And usually they did not do well. So sometimes it can be helpful to let you know that something's going on with them, but is it worth $50 for every single dog that's out there? I don't know about that. That's my opinion.
At NC State, we called it a Big Four, but we did it every, I think 12 hours on pretty much every ICU patient. And it was expensive. Yeah.
And again, that's good to do if they're not charging them every time they do it. But if you're charging them every time you do it, number one, it takes a lot of tech time, which as you can see, the techs can get very well behind if you're doing that all the time. And if you're charging them at certain places, like most places do, that's about $100 in testing right there. Like, do I really need that if my dog's doing okay? And I think the problem too in veterinary medicine is we call everything ICU. And it's like, some of this stuff is not true ICU, in a human setting. This is more of just a med surg ward, So again, it's just, I tend not to think, like treat everything like exactly the same. And that's where, again, too, where they're looking a lot at the medicine, but they're not treating the owner. If your owner can't afford $100 in testing every day, why are you running that every day, especially if it's costing you that much? Run that, once a day, or don't run it at all if the dog is totally fine that day and you done your exam and you feel the dog looks pretty good on exam.
Preach. Totally agree.
So we get a blood pressure is 60. So what are the limitations of blood pressure? So there is
it's not accurate in the hospital with these animals.
Yeah, oftentimes it's not accurate, right? And so in this dog being down, lethargic, I have a heart rate of 180, I would believe it, but I've seen plenty of cats, especially cats or smaller dogs, these little French bulldogs, things like that, where you get a blood pressure of 60 and they're walking around acting fine. You're like, what's going on? And then you definitely, if it's a cat, don't want to start bolusing that thing fluids. You might, you can easily overload a cat if you start getting crazy with that, or giving, again, spending money you don't need to spend. So, you gotta be careful with the blood pressure. It's a test that is often, I would say, inaccurate, probably about 25, I don't know, somewhere 10 to 25% of the time, I would bet it leads you in the wrong direction. So look at the rest of the animal. Don't just look at the blood pressure itself, the reading, but does the animal fit with that reading? If it fits with that reading, okay, you have to put some weight on it. You have to believe it. If it doesn't fit with that reading, then maybe you need to consider is something else going on here. Jesse, what is the right way to check a blood pressure?
All right. So the patient should be in a right lateral position. And then you need to use the one that is most level with the heart. So I would use, depending on where the IV catheter is, I would use one of the topmost legs. I would then get an average of the three numbers. I would prefer just using a Doppler, but that's just personal. However, sometimes like getting a patient in lateral freaks them out and it messes with the results that you're going to get. So there are times where you need to just get a blood pressure with how they are, just in my opinion. But yeah, I think that's it.
That's exactly it. So, and that brings up some important points here, right? So the right way is to have them in right lateral, get a serial, do 2 or 3. How long would that take you to do it the right way?
Well, depending, okay, so if this is the patient, so it's at least a two-person hold. Um, Getting the supplies. So anyway, and getting all of the readings, and then the average, I would say 4 to 6 minutes, depending on the machine.
Yeah, and I would say sometimes even as long as 10 minutes, right? I mean, if the animal's not being cooperative, and you know it can take a little longer, right? So it's not like a necessarily always the easiest thing in the world to do. Sometimes I see we put blood pressures on there every 6 hours, and for the past 2 days they've been normal. I'm like, well, why don't we just take these off, right? Because this takes some time. I only have a few technicians. Sometimes somebody calls out. So, it's not always the easiest thing in the world to do. So, keep that in mind when you're requesting a blood pressure. And yes, I would say a good number of the times I'll see techs checking the blood pressure, and the animal's like standing up, and they put the cuff on and just check it that way. And that can artificially elevate your blood pressure. So when you see inaccurate readings, there's reasons why the techs do it like that, because sometimes laying them down makes it bad too, right? So there's just not a perfect solution. Sometimes I think some people just don't know, and so we just have to teach them. But sometimes, like Jesse's saying, there's good reason, because they found that they did the other way. It wasn't any better. And the studies that are out there, they have animals that are usually sedated. That's why they can do it like that. So just keep that in mind. But there are definitely limitations to blood pressure. There are definitely inaccuracies you need to be aware of. Pulse oximetry, I would say, is even worse. I don't even do pulse oximetry in an awake animal. I would say if you do pulse oximetry in an awake animal, you're going to be treating something that you may or may not need to be treating about 50% of the time. Even in under anesthesia, sometimes that machine can give you, inaccurate readings, but for sure, in a dog that's awake and moving around, I wish we could figure out a way to make it work on dogs that are awake and moving around. I've often thought, I wonder if you could like shave the tail is kind of like a finger. So I wonder if there's a way you could shave the tail and put it on the tail, but I just haven't found the way to really do that yet. So we do
We
an ultrasound. Go ahead.
we've done that where we shave the tail and like vet wrap it to the tail, and but that's on like a immobile patient.
Yeah, yeah.
Yeah.
And I tried to do it on awake ones. I even I literally shaved an animal's tail, but I found it wasn't. I was like, this is weird. It's like a finger, but it still wasn't. I could get it sometimes, but it just wasn't like it seems like a human. Every time you go into the hospital, they put that thing on your finger and they always get a reading. And it didn't seem like, I would think the tail would be the perfect thing on an animal, but I just didn't find that to be the case. I even had an idea, like, I'm gonna invent something. I'm gonna invent a little pulse oximetry machine that you can put on the tail. But I just haven't found that those machines work that great. Maybe I don't know. Maybe I'm just doing it wrong. So we do an ultrasound. We do a point of care ultrasound. And we see some scant pleural fluid. We'll talk about ultrasound and POCUS later on, because I want to get to the other stuff. And then we could honestly do abdominocentesis, thoracocentesis, right? is this a good idea in this animal? Should you do it? Should you, if you see this scant pleural fluid, should you go ahead and do a thoracocentesis on it?
I wouldn't without knowing clotting times.
Yeah.
And if the dog is presenting like it's hypovolemic shock, then it's most likely blood.
Yeah, so you might want to get some more information. I don't think you're going to kill it by getting the sample, even if its coagulation times are way off. But ideally, I would want to know the coagulation times. I would want to know more about the history. Was it exposed to any toxins? And if it's scant, I'm going to be careful because I'm more likely to cause damage, right? So let's just say there's too little. You decide you're unable to do it, but you do want it. You do want it, but there's too little in this case. So now we're going to look at our problems again. We have an animal that's hypotensive. It's tachycardic. I do believe these pulses are weak because it's hypotensive. I do believe all this other stuff I'm seeing here is lactate's a little high. It has some pleural effusion. It has a decreased total solids. It's tachypnea with no effort. So, I would say I'm even more confirmed here right now that this animal is probably in hypovolemic shock. My ECG was a sinus tachycardia too as well, right? So, I know that sinus. So I do think it's in hypovolemic or hemorrhagic shock, or maybe that's a pyothorax. Maybe it's in septic shock, right? So I'd say either one of those, could be possibilities here. I may need to get that. I may need to get that sample to confirm that. It may not be hemorrhage, right? So what is your treatment plan at this point, or what do you want to do? Do you want to give fluids? If so, how much and what type?
Fluids, P-Light, or LRS, twice maintenance.
Yep. So we did this the last time, right? We gave, replacement fluids, right? Now you said twice maintenance. I would say I like the P-Light, I like the LRS, I like the you could even use sodium chloride, 0.9% sodium chloride, but I don't like the twice maintenance. How might you change that part of it?
Why not? Why don't you like the twice maintenance?
I would give.
Go ahead, Joe, because we did this the last time.
Yeah.
See if you remember what we talked about before.
We talked about like shock doses being different than like maintenance and like regular fluid therapy. So giving a quarter of a shock dose, so like 15-20 mils per kg in a short amount of time.
Yep, exactly, right. So this is we're giving a shock dose to this animal. And I clearly remember, Jesse, you just reminded me of something. When I was in my clinical rotation and from Ross, and I was in my, I was at OSU at Oklahoma State, and I interviewed at AMC, and they had me on a phone interview, and they started asking me a bunch of questions. And one of the things they asked me was about shock doses and things like that. And I just like totally blew it. I just I couldn't remember if it was 60 mils per kg per day or 60 mils or 80 mils per kg per an hour. And then I started fumbling on the phone call. I was like, man, I'm not getting that. And I did not get into there. I got into Saskatoon, but I totally screwed that. I remember when I was in Saskatoon, I mainly did a lot of like emergency type stuff that was not like dying. There was a couple and we were on them by ourselves at night, and I screwed a couple of those up. But I remember when I came into Tufts, and then I had my first hypovolemic dog that came in for vomiting or something like that. I was very dehydrated, and the heart rate was really high. I'm like, what am I going to do? And the technician said to me, "Do you want to give it a fluid bolus?" I'm like, yeah, I want to give a fluid bolus. And she's like, how much? I'm like, and I was thinking, she's like, a liter? I'm like, yeah, a liter, right? So that's where your technicians really can, sometimes they've seen things that you haven't seen, and sometimes they can help you, but and be your best friend. And that's why you want to have a good relationship with them, because none of us know everything, and we, have to work again as a team. We're all going to be much better as a team if we do that. But yes, I want to give this dog fluids, and because it's in shock, I don't want to think about maintenance, replacement, ongoing losses at this stage. That's more for my dehydrated animal, where there's mainly interstitial and intracellular losses. But this dog has I think vascular loss is causing that hypotension. So I'm going to give a shock dose at this point. I'm not going to give the full, shock dose in a dog, which is 80 to 90 mils per kg, but usually I'll start with a portion of that. A quarter is a pretty good number, but if it was a dog that had a heart murmur, I might start with, 10 mils per kg instead of 20 mils per kg. If it was a dog where I saw there's, half of its blood volume on the floor, I might give more 40 mils per kg and maybe even start grabbing for blood a lot sooner, right? But the fluid that I would use is going to be a replacement solution, and the amount I'm going to be thinking of here is going to be shock doses. What about oxygen?
So just back to that
Mm-hmm.
shock dose thing.
Mm-hmm.
The whole quarter dose shock dose thing is new to me, because like way back in the day, it was like always. But all the conferences I've been to agreed. They're like, do the quarter shock dose.
Yeah. So
So
if
anyway,
you look at a shock dose, right? 80 in a dog, 80 to 90 mils per kg, and in the cat, 50 to 60 mils per kg, right? So where does that number come from?
It's
Blood
equivalent
volume.
to blood volume and
Yeah, it's the blood volume of that animal, right? So does an animal, that has lost, 20% of its blood volume need a whole blood volume and fluid? No, right? It maybe needs, it will probably need at least that 20% and maybe a little more, because some of it will go into the interstitial space, right? So about 2/3 of that will. So, and you don't necessarily need to fully resuscitate it. You can do that over a little longer, but you're going to probably at least give about, a quarter, if it's lost about 20% of its blood volume, or about a quarter of its blood volume, or a fifth of it, I guess, then you would, give about, 20 mil per kg bolus, and that's going to potentially fix that animal for you. So, again, all of that shock dose tells you is that if I give a shock dose, a full shock dose, I've, given a full blood volume to that animal. And so now, I've given a lot of fluids, and I may, I got to start thinking, is there something else causing this shock? Is it vasodilation? Is it that there's obstructive shock, say to like a GDB? And we could talk about different forms of shock the next time if you guys want. But is there something else that I need to address? Maybe this is not just a fluid issue. Maybe it is. Maybe you do need to give more. But if you start giving up to that shock dose, you really got to start thinking what's going on. And so, yeah, the concept of just giving a full shock dose has pretty much gone away. And I don't think that even when I was in my internship too, I think a lot of people misunderstood it. I don't think that the maker of it, or the person who came up with it, ever meant it to be that way. But that's what a lot of people acquired from it. But really, it's always been given a quarter of it, or half of it, or a fifth of it, and then reassess, and then give some, and then reassess. Give as much as needed, as little as possible. And then oxygen. So do we need this dog to be on oxygen?
Okay, I want to say gold standard. Sure, why not, right? But
Mm-hmm.
however, with this patient that we are talking about, the fact that it's pink, it's not blue or muddy, it's a little pale pink. Perfusion is everything. The lactate shows a bunch, but I think if costs were concerned, the patient doesn't need to be in like a Schneider, maybe some flow by while you're like getting IV catheter examination. But in the end, I don't think it needs to be on like a high flow or nasal cannulas or anything of that nature.
I would 100% agree with that. So, if you're, trying to initially stabilize this animal, sure, give it some flow. I honestly am not a big fan of the mask. Sometimes I knew a guy who had a bad pulmonary injury, and the medics kept trying to make him, like, I think they kept trying to put something in his face, and they kept trying to like stress him out by doing a bunch of things. And he said it made it worse, right? So they were trying to, put a mask in his face, and they're trying to make him sit in a certain position. And he was like, I need to stay in this position. I need to get that thing out of my face, right? So I think it's the same thing with the dogs here. If we start shoving that cone in their face, and they're stressing out and they're fighting it, right? Stand back, just let it blow by their face. Don't necessarily force it in there. And if you don't, if you're this dog, if there's no effort, it's pink, it's just having a little bit of increased respiratory rate, that easily could be stress, right? So that's a big person who's real stickler on this one is Dr. McDougall. She hates when dogs are put in oxygen, they don't need it. And I exactly agree with what you said, Jesse. Like, a little bit of oxygen in the initial stages, that's not a big deal. But putting it in the Snyder and burning oxygen all night, like that doesn't make any sense unless you really think it needs it. Now, if you're not sure, I get it. You don't want to not do it and wish you had. But if you see it, hey, this is not a respiratory dog. I'd rather you just take some X-rays and make sure there's nothing going on in the lungs. And as long as it's not, it's pink and it's breathing okay, and you treat it with some fluids and the dog gets better, then you're good to go. You don't need to keep it in that oxygen cage all night and burn all that oxygen. And it is expensive to the owners, right? So at this point, we're going to go ahead and get our history. So we started our process of stabilizing this dog. We decided to give it, a quarter of a shock dose. We decided that, it did not need oxygen, and we're going forward. So now we can go and start getting more information from the owner. It's always important to get a full history, right? So, most people would say, I've seen a lot of texts to me back in Blue Pearl days, why do I need to, Dr. Wynn, who was our nutritionist over there, was really big into diet, and she would have us ask a lot of ridiculous questions, but they're like, I don't even need to ask about the diet. I'm like, no, if it's on a food allergy diet, we need to know. So, you definitely want to, even ask some of the more silly questions. If it's a dog, vaccines, if it bites somebody, the first thing they're going to ask, was it vaccinated? So you definitely want to, ask those types of questions as well. The I can't did I put vaccines on here? I didn't put that one on here. I missed that one. But yes, that would be an important question to ask. A lot of times I don't try to lead owners to questions, so that my first question is always is well, why are you here? And then I let them kind of just answer that. These questions here, like what diet, current medications, vaccines, things like that, heartworm, flea, and tick. A lot of times with those questions, I know I took this off here because it was a military dog. This is a military dog, and of course it's going to have vaccines and heartworm. But a lot of those questions, I'll use that little form that we have, because if I don't, the owners I just need to know yes or no. I don't need to know all the details. And they'll try and look it up on papers, and it makes the conversation go a lot longer. I don't know if you've ever been in this room with those owners, and they keep talking and talking and talking. You're like, why is life doing this to me? I mean, this is just sucks. I'm literally thinking in my head, like I'm hating my life right now, right? Because they're just going on and on and on and on about something that I'm like, I need to go back and save your dog, but I don't want to be rude. But really, what you're trying to look up on your piece of paper right there is not important. I just need to know, was it vaccinated within the last year? But again, so that little QR form I find helps me quite a bit. I think Anderson, I think you use it quite a bit too as well, right?
I do, yes.
Yeah.
And I totally agree. Like the on and on, like just the facts, ma'am.
Yeah, just
That's what I'm
yes or
saying.
no. Yeah,
Just the
is it?
facts.
Yeah.
Yes or no.
And then a lot of times too, if they say yes to like important like a toxin, I'll ask them more details about it. In this case, the owners say anticoagulant rat poisons are in the kennel, but the dog cannot reach them. And so we've talked about this already, but we know that these interfere with vitamin K, the enzyme that's important in the production of functional clotting factors 2, 7, 9, and 10. And if you don't have, it doesn't limit vitamin K exactly. It limits an enzyme that vitamin K is important in working with. And so and what it does is it doesn't prevent the clotting factors from being activated. It just prevents them from the liver from producing a fully functional clotting factor that can then be activated. And so, yes, if this dog had gotten into that, that could cause bleeding into the chest, right? So you get your full physical exam now. You have an improved heart rate, your pulse quality is better, your CRT mucous memory is better, it's breathing good, and everything looks good here. So lactate and blood pressure also improves. So now you got a new problem. And my point here is that, the concept of soaping an animal, if you guys notice, I always put a time on it. Like I put my assessment was at this time, my plan was at this time, and then my communications at this time. And that way, okay, this soap applies to this animal at this time in the day. If something changed after that, that's because I didn't see that after that. And this soap at this assessment applies to this conversation with the owner at this time, not to that future conversation where I talked about something else that, that assessment is now null and void. Because you are constantly soaping that animal every minute. As you get new information back, the soap changes or your assessment of that animal changes. So that's why I have that, some people might look at like, why do you have that time in there? That's weird. But again, as I realized as I was doing this, I'm like, no, I'm doing this constantly. And it might what my assessment looked like at 12 o'clock may be completely different at 1300 when it's an hour later, and things that maybe change or I have new information back. So now we have plural. Go
I
ahead.
actually love the time. I love that you do that.
Yeah,
That
and you can
That's
see
and I'm
where it
great.
is
doing it
with that
too. I'm
conversation
doing
as
it too
well.
now because it is so important.
Yeah, I think so. Me too. I'm glad you say that. Thank you.
I feel
So,
like something I know like it's different when like the doctor goes into the room and a tech goes into the room and they typically keep doctors there longer. But
oh
I
yeah.
try to stick with the Shed C, like signalment, health history, environmental, diet, like that type of thing.
Mm-hmm.
And diet includes like the medications. So like I confirm the signalment, like are we actually spayed or not? Significant health history, like any pertinent health history I need to know now, diabetes, Cushing's, like anything of that nature, crazy past surgeries, and then, okay, what are you feeding, including medications, things of that nature. But then the environment would answer that question right there, right? Like the environment is like how many animals in the household, like is there a creek in the backyard, are we thinking lepto, or like have you had your house recently treated? And it really gets them thinking about like, okay, now I'm going to move on to the environment, like any new things in the house, construction, like all these little things. And then after I get to the point, I'm like, okay, gotta go.
Yeah,
Thank you for answering those questions. But I feel like sticking with Shed C in the rooms, getting, especially in emergency medicine, it helps the most. And I was taught that with my anesthesia stuff, like pertinent information. And then thank you. If I have any more questions, I'll come right back. Or if you
I
think
like
of anything else, please let the front know and they'll tell me.
I like that. And kind of like the 5 R's or whatever, those little things are very, very helpful, and making sure you check off all your questions you need to ask. Very good. So yeah, so our new problem is now pleural fluid, low protein, improved shock, improved respirations. So I'd say, we can make differentials for all these problems, right? But again, if we put them all together, I'm going to say, hypovolemic hemorrhagic shock is still at the top of the list here. And we know that this fluid could be a, modified transated and exudate. It could be septic exudate. It could be blood. It could be chylous effusion, right? We know that we talked about hyperproteinemia could be due to um, uh, that you have protein loss to the GI tract, protein loss to the kidneys, liver disease, third spacing from sepsis. The respirations we don't need to worry about. We can take that off the list now. But the one that, fits on pleural effusion, hyperproteinemia is bleeding, 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 right? So I think that with a possible anticoagulant exposure, I'm going to say that this hypovolemic hemorrhagic shock is going to be now at the top of my list. And that's going to, what I put at the top of my list is now, why is that important? Because that's going to affect what diagnostics I'm going to do. Am I going to spend that money on doing the PT-PTT? Yes, 100%. I'm going to spend that $160 because, this animal has exposure to it and has some evidence that that could be going on. So, and I'm going to get a CBC2. I get a CBC. There's a mild anemia, stress leukogram, mild ALT elevation, low albumin. I see LT elevations all the time. I'm not going to start thinking liver now. I mean, that could just be shock, right? And then I got a PT that's prolonged and a PTT that's normal. So that is classic for what?
Anticoagulant, red
Emo abdomen.
Yeah, well, yeah, and that would be our anticoagulant rodenticide, right? Because which the PT test the extrinsic system, the PTT test the intrinsic system. The PT starts with factor 7. The PTT starts with factor 13. If I remember correctly, maybe it's factor 12. No, it's 13. Double checking on that one. But the PT definitely starts with factor 7. Which one has the shortest half-life of all the clotting factors? Factor 7. So as you consume clotting factors, you have to get down to, I think it's around 30% before you get prolongation in your clotting time. But as you get down to 30% of the factor 7, which tends to have the shortest half-life, so it goes first, your PT will start to be prolonged. And so a lot of times when you're looking for an anticoagulant rat poison, you look to see if you got a greater prolongation in your PT than your PTT. Now, if it's been a while that it's had that rat poisoning, they both will be prolonged significantly. So it's not always that your PT is longer than your PTT. It's not like it's always like that. But if you see that, and especially if they have a history of it, that's pretty convincing evidence that that's what you have. You can test for rat poisons, but that's not an easy thing to do, and it won't come back for a week later. So really, testing your coagulation times, the history is how you're going to know if you need to treat it or not. I take a chest X-ray and I see a wide mediastinum, right? So this is a wide mediastinum. That's a pretty classic finding for a rat poison. They tend to bleed, and your low platelets tend to have like nosebleeds and GI bleeding. Your rat poisons tend to bleed in the pleural space and in the mediastinal space. They can have a hemoabdomen. They can have nosebleeds. They can have GI bleeds too. So they all can do the opposite thing, but we tend to see more of bleeding into the body cavities with the coagulation problems with the clotting factors, and we tend to see more nosebleeds and GI stuff with the platelets. This is real easy to miss. I've missed this before. I had a dog with a thyroid carcinoma, and I couldn't figure out where it was bleeding, where it was bleeding, where it was bleeding. This is when I was at Saskatoon, and I'd be there by myself with just me and the technician, and the radiologist comes the next day. It's like, oh, look, it was bleeding into the mediastinal space. But this can be very easy to miss on an X-ray. It's just not an area we often pay attention to. So we got our new problems now. We got the prolongation, the PT with the normal PTT. That's going to put an anticoagulant rat poison at the top. We got fluid in the mediastinal pleural space. It could be all these, but I'm worried there's going to be hemorrhage. We got a low albumin. I'm worried that's going to be the blood loss. We got improved shock, which we think is hypovolemic, and mild ALT exposure, or other mild ALT elevations, stress leukogram, possible anticoagulant. So for sure, high on my list now is going to be an anticoagulant toxicity, enough that I'd probably go ahead and start treating it, right? So now we're going to set up our treatment sheet. When you're setting up your treatment sheet, Joe, I think you've seen this before, you can just do that hospitalization too. That usually gets you all the things that you want to put on there. It's real easy. The reason why I talk about treatment sheet here is because we all get focused at this stage. We're kind of nervous. Our heart's kind of racing. We don't want to lose this dog. We can just talk to the owner. The owner's got, I don't have a lot of money, so we had to go through a whole money conversation. It's real easy for us to miss things like the walks or, the food and water. It's also really easy for us to get crazy on doing things that we may not need to do as often, because we want to be careful. So, use those templates. They'll help you not to miss some of those things, especially like, doctor to check the treatment sheet once a day and assess the charges and all that stuff, right? So make sure you, just like you're going to focus on getting a good history, you're going to focus on making a good treatment sheet, and those templates will help you out. So how are we going to treat this? Vitamin K. We're going to get some vitamin K. That will, what it does is if you give high levels of vitamin K, you can use enzymes other than vitamin K epoxide reductase to make functional clotting factors. You use an enzyme called DT difurylase, and now you can make functional clotting factors that can be involved in clotting, but it's going to take some time. It's going to take like 24 to 48 hours before that vitamin K can do that. So if you have a dog that's actively bleeding, or that dog I had the last time that came in coughing up blood, I went ahead and gave plasma because I knew if that dog bled into the lungs, I was fucked. I was not going to be able to save that dog. But if I could stop it from bleeding into the lungs, because it's already having some bleeding, we could see it on x-rays, then I knew that, I could maybe save this dog. And so we gave plasma. So how much plasma would you give, and how would you do that?
Can I ask you a question?
Yeah.
So Charlotte, I don't know if you were involved with Charlotte, but that dog we thought was a toxin of some sort. And so how do you feel about just doing vitamin K? Like, what the hell? Like, it's not going to hurt anything.
It's not going
That's
to
what
hurt
I
anything.
did.
No, it's not going to hurt anything.
So
And I've definitely
that's what poison control said to do. Like, we did it. The dog died anyway, but I just wanted your thoughts about that.
I would say if I have one that, I'm worried that, hey, maybe this is a rat poison, but it's not actively, bleeding. Yes, I would give vitamin K. If I had one that, is actively bleeding, PTTs prolonged, I'm going to give some plasma and vitamin K. But, if I have a suspicion for a rat poison, I think maybe that's why. Then yeah, definitely I give some vitamin K. I would definitely run a PTT, see if you can confirm it that way.
And it was like off the charts. Yeah.
Off the charts. Yeah, then I
Yeah,
definitely
it
would.
was. Yeah.
The problem with that one's going to be those, you probably, no matter what the cause of the prolongation is, you're probably going to need plasma as well too. So I think the important point there would be that the vitamin K is important to do, but it may not be the only
Yeah.
thing you need to do.
Yeah, we did plasma. Dog died anyway. Poor Megan. Megan had to deal with that.
I was going to ask a very similar question. Oh, I'm sorry. Were you done, Dr. Inston?
Yes, I'm done. Go.
Okay. I was going to ask a very similar question about like prophylactic. So if there's a concern that they got into rat poison, but they're not showing symptoms yet, like they call you up, say, I think I got into rat poison. Do you just start vitamin K prophylactically? Do you do a full course?
Yes, so this is a great question. So if the owner is concerned that they got into a rat poison, yes, I would probably just give a full course of vitamin K. That's the easy part of it. Now, would I check? Say it's day one. Day one. They think it ate the rat poison and they're pretty confident it did. Do I check a PTT and a PT?
Wait to the next day or even 48 hours, I think.
I don't think I'd even check it at all, right? Because I'm going to give it vitamin K. I'm not going to wait for it to become prolonged. Now, you could do that. You could wait for it to become prolonged and give it. But the first day that they eat it, really what's going to tell you whether you need to start vitamin K is how confident are that they ate it, or how much risk do they want to take that it did not eat it, right? So if they're pretty confident it ate it, it's not going to be prolonged yet. It's going to take about 4 or 5 days for that vitamin K level to drop enough to for that I'm sorry, those clotting factor levels to drop enough that it's going to have bleeding. So you usually don't see, it's not an acute toxicity. In other words, it doesn't happen within the first 24 hours. It takes 3 or 4 days, for that to happen. Some people can say as long as 5 to 7 days. So you really won't get those prolongation and clotting times until, days later. So if the first day they come in, you don't even have to check clotting times. If there's a good chance they got into it, then you're just going to go ahead and give the vitamin K.
And then follow up with clotting times?
Yeah, a lot of times what I'll do is I'll just give it. I used to get real scared and, have them, recheck clotting times in a week and make sure the vitamin K is working. And they can do that, and that's not wrong to do. What I usually do is I just give them a good dose of vitamin K that should work. And then usually I'll have them go back to their vet once they stop it, about 2 days after they stop it, and make sure the clotting times are good. And if you look at my discharge for the vitamin K toxicity, it has like a whole protocol, like, give the vitamin K for this long, and then about 2 days after you stop it, go to your vet and have them recheck clotting times. But there is one actually in there.
Yeah. So fortunately, Joe, you're not going to see a lot of this. I saw a ton in commerce. Like every dog had, like, the exterminators were terrible. They would tell people, oh, dogs won't eat this rat bait. Okay, well, yes, they do. So, Joe, you're probably not going to see this, but this came up recently. So, yeah, I just thought I'd ask.
Well, it's
Also,
fun.
in the pest control world, they're leaning away from using these types of poisons because of these problems that we are currently being educated on. And so they're using, I can't remember what it does, but it's like increased calcium, or it's like I don't know, it's a whole different mechanism of toxicity that's not treated the same way, but that's what they're actually starting to lean more and more to, especially in like the southeastern region.
Yes. So you have your anticoagulant rat poisons, which is like difenysanone, brodifacoum, bromodiolone, and they can be first or second generation, with the second generations being longer acting and act much faster at lower doses. But your first generations are even drugs like warfarin that they use, medically to prevent coagulation. And now we have newer drugs that we use, but it was an old drug that used to be used for people who are prone to blood clotting disorders. And then they have your cholecalciferol, which is your vitamin D essentially, and that causes
There it is. That's what I
hypercalcemia.
was talking about.
That causes hypercalcemia. And then you have bromethylene, which is a neurotoxin, and that causes more neurologic signs. The funny thing is yes, they decided that, if you guys get kicked off, it'll probably, I can just sign right back in. I'll sign you back in, but sometimes teams will kick you off after an hour or so. But the funny thing is that, like Jesse was saying, they decided that, the anticoagulant ones are bad and let's use these other ones, but the other ones are less treatable. I'd way rather have an anticoagulant with decide than Brodipicum or, I'm sorry, yeah,
I agree with
Brodipicum
you
or,
on a nursing standpoint. I agree with you. They're a lot harder to deal with, to diagnose,
yeah.
to just it's more difficult even on the nursing standpoint. It's
Well,
a
and
lot more.
prognosis wise, I
So
mean, they just,
Jesse, I think you're talking about the bromethylene. Um, you're talking about the neuro.
well,
Rep.
they actually, even the anticoagulant ones, they were trying to, like, the government, I think it was, or somebody was saying they don't want to use those as much and they wanted to switch more to bromethylene and cholecalciferol. The problem is when those guys show signs, you can't save them.
Yeah,
So,
that is terrible.
yeah.
I remember. I will never forget the neuro bromethylene cases I've had.
Yeah,
So
I never understood why they wanted to do that, but yeah, that was a thing, and it didn't make any sense to me at all. Like
okay.
you guys were saying. So if in this dog, we're getting kind of late, so I won't keep you guys too much longer. But I'm gonna give this dog, somewhere around 10 to 20 mils per kg of plasma. Some people say you should cross match. I never cross match for plasma, and it's more would be like a minor cross match you would be doing. In other words, like is there antibodies in the plasma that are going to react with the dog's blood? So I don't really worry about cross matching them. And cats, they say it's a little more important, but again, I don't really even cross match the cats for a minor cross match. Um, you can give plasma with fluids. With blood, you don't like to use calcium-containing fluids because the calcium can cause the blood to form little clots in it. So we tend to avoid things like LRS, but we could use like sodium chloride. And even if you gave LRS, it's not enough calcium in there with the way you're mixing it that it likely would cause an issue. But some people will get real mad if you mix LRS with your blood. But you certainly can use sodium chloride. There's no calcium in that. And what
That's
if you only go ahead?
in the same line, or would you want a separate catheter?
You can view them in the same line if you for some reason you could only get one line. But ideally, if you're giving high volumes, you may want to use separate catheters.
Yeah.
So in general, yes, it is nice to use separate catheters for giving different solutions. But sometimes, when you put like 3 or 4 catheters in a dog, you do increase the chance that you can have complications from those catheters. And it's expensive to place those catheters. And if you only need to do it for a short period of time, I would I felt like I needed to do it. I mean, a lot of times I can just give the plasma and then give the fluids. It's not a big deal. But, if I felt like I needed to give both and I didn't want to place in an extra line right away, I just give both in there. And I would just use a low calcium containing fluid or like sodium chloride if I was really worried about the calcium, especially if I'm giving blood. Plasma's not as big a deal. Plasma's not going to clot. Now we have fresh frozen plasma and we have frozen plasma. So fresh frozen plasma means that I took the blood, I spun it down, I separated the red blood cells from the plasma, and I did that within 6 hours. So what is the difference between fresh frozen plasma and frozen plasma? Because frozen plasma, you let that blood, so you separated it after 6 hours, or that blood sat in the freezer for more than a year. So there's a difference between frozen plasma and fresh frozen plasma, and frozen plasma is lacking 2 clotting factors. Do you guys know what those are?
This is news to me. Like I'm interested.
I knew at
Yes,
one
I'm
point.
trying so hard to pick my brain. I
So
think
it's
I
lacking
think
5 and 8.
okay, that's not what I was gonna say. So
Okay.
Those are what they call the heat. Those are what they call the heat liable factors. So frozen plasma, the point here is frozen plasma still has 2, 7, 9, and 10. So you could use frozen plasma for a anticoagulant rodenticide. So even if you had old plasma that's been sitting in the freezer for more than a year, or plasma that was not corrected appropriately, or maybe they thawed it out and then refroze it, you could still use that as for vitamin K toxicity or anticoagulant rodenticide toxicity, but you could not use it for like a hemophiliac, or you could not use it for it wouldn't be as good for like DIC. What about platelets? Does plasma have platelets in it? No platelets. So those platelets burn up very, very fast. So if you're trying to infuse platelets into a dog, you have to give a platelet concentrate. It's not easy to get. And oftentimes you're trying to get platelets to ITP dogs, and they just burn up those platelets as fast as you give them. So it's only helpful in those dogs when they're actively bleeding to stop the bleeding, but those platelets are not going to last you very long. You're definitely not going to increase platelet numbers with it. So we don't use a lot of platelet transfusion just to the logistics of it, and just because, you know, there's many cases they won't work for. If you had a dog with von Willebrand's disease, you know, you could use plasma. A hemophiliac, you could use plasma, but it's better off to use concentrated solutions like cryoprecipitate for von Willebrand's disease. But again, those sometimes are hard to get, so we'll just use plasma for them, although you have to give them quite a bit of plasma. What about for increasing albumin? If I wanted to take a 20-kilogram dog and I wanted to increase its albumin by 1 grams per deciliter, how much plasma would I need to give? And if you had you have to give about 45 mils per kg. So that's going to be about 2 units. So if you're using plasma to increase albumin, you have to give a lot of blood. It's expensive, and it doesn't increase it by that much as you would think it would do. So I tend not to do that. I will say there's a couple of dogs that I've seen.
Useless,
You know,
right? Useless.
yeah. What's that?
Useless.
It's
Albumin and dog useless.
agreed. And there's a couple of cases where I've seen, you know, if you want to use it, if you want to increase albumin, you have to get canine albumin, which is not hard to get, which is hard to get. I'm sorry. There are a couple of times when I used to say plasma in dogs is useless. In other words, in humans, they don't use plasma to increase albumin. They only use plasma for, you know, clotting abnormalities, right? They don't ever use it for or they use it for like bleeding patients where they're losing blood and plasma, and they'll actually do like 2 units of blood for every 2 units of blood they give 2 units of plasma, and they give a unit of platelets. So they try to replace everything in their bleeding patients, but they're not doing it to, you know, restore the proteins. They're doing it to restore not just the proteins, but the everything, the clotting factors, the albumin, the blood, the
But wouldn't
platelets,
that be
and
like
they're
just
trying to.
way too many colloids? Like way too many, right? All at the same time?
Well, let me go back. So in bleeding, right, where's all the blood lost? Is lost in the vascular space, right? So if I lose 50 mils of blood from the vascular space, and I replace that 50 mils, you know, that I'm good. I'm good to go. But if I have a dog that has like SIRS and it's leaking fluid and proteins out into the interstitial space, or if I have a dog that has a protein losing enteropathy or protein losing nephropathy, and I try to increase their albumin by giving plasma, well, they're not just lost, you know, from the intravascular space, but they're lost from the interstitial spaces and everywhere. So it's going to take a lot more albumin than a dog that just lost from the intravascular space. And a lot of times, as soon as I put it in the intravascular space, it just leaves out the place where it was losing it. So really what I need to do with those dogs, whether it's a sepsis dog, whether it's a protein losing enteropathy, protein nephropathy, is I need to correct the underlying disease. And that's how I'm going to get, you know, my proteins to come up, is correct the underlying disease. But if you wanted to try and correct it, you have to give a lot because they're losing it total body. So you have to use like those protein concentrates, or like, you know, those albumin concentrates. We used to use human albumin in dogs, but it caused a lot of allergic reactions, and they think it was killing the dogs. So now they use canine albumin, but that's hard to get. Now, with that said, I have seen one situation where I think a plasma in a dog may be helpful. And there is dogs that sometimes they'll be in shock, and, you know, no matter what you're doing, pressors, fluids, whatever, you can't get them out of shock. And I've seen criticals do this. So like, give it a unit of plasma, and the blood pressure comes up. And you're like, oh, it's because of the colloid effect. And maybe that's it. And maybe it's just not recognizable in the numbers. But maybe it's that there's certain things that plasma is doing that we're not aware of. There is something called the glycocalyx, and if the glycocalyx is damaged, then you get more leaky vessels. Maybe it's somehow repairing. You know, there's factors in there that are repairing that glycocalyx. I don't know, but, you know, I would say as a Hail Mary, if everything's not working and you want to try it, that's not wrong. But in general, you know, trying to use plasma to replace proteins is not a good idea, in my opinion. That makes sense?
Makes sense to me.
Yes.
I feel like there's a lot
Yes,
of
it did.
information there, but Okay, so now
you're kind of a savant.
a
Okay.
what?
You're kind of a savant about that kind of stuff.
Well, thank you. So now let's say 1 hour later, the dog's now has a PCV of 13% and a total solids of 1.5 grams per deciliter. The pulse is 180 and bounding. The mucous membranes are pale, and the dog is dull. And we look at the heart, and the left ventricular chamber is small. It has a normal cava to small cava, and there's a small left atrium, no B lines, scant pleural effusion, large amount of mediastinal fluid. So what's happening? This dog is obviously bleeding now, right? So he's bleeding, and we need to do something about it. So do we want to give blood? At what PCV do we give blood? What would you give, whole blood or packed red blood cells? How much blood would you give, right? So do we want to give blood? I would say yes. At what PCV do you give blood? I'm gonna answer some of these questions for you guys just because I want to make it go a little faster. But there's not a correct number there. Is the point behind that question?
14.
Yeah, 14, and I would say 14, 15 is a point where I get nervous for sure, and I'm probably going to go ahead and give blood. But the other part of that question too is that if you have a dog that has acutely bled, it might start showing signs at 20% versus a cat that has, chronic kidney disease and, has had that for a long time. They may be sitting pretty at 18%, right? So there's not an exact
Yeah.
number, but yes, I would agree that when they get down to 15%, 14%, man, do I want to really, even if they look good, do I want to really wait till they get bad? Like, I'm pretty sure they're going to get bad pretty soon, right? So I might consider just being proactive in that one. But also the other side of that equation is I've had owners that, have like bleeding ulcers, and the owners have no money, and the dog will be at, 13% or so, but it's looking okay. And I've said, let's just, treat aggressively for that ulcer, and the dog's done okay. I've also treated aggressively for the ulcer, and the dog dies, right? So, there's just there's not a right or wrong number there, and there's going to be multiple factors that are going to come into play as to whether you give that blood or not at that PCV. But, again, just understand that if it's a chronic loss, you could maybe be able to go a lot lower than if it's an acute loss. And do I want to give whole blood or packed red blood cells? Well, if I have like an IMHA case, I'd rather give whole blood. If I have a packed red blood cells. Where it's just losing red cells, right? Or just lysing those red cells. Versus if I have a dog that can, like this dog that could benefit with plasma and blood, then maybe I give whole blood, right? Or if I give blood, I give some plasma with it, because it's losing both plasma and red blood cells in a hemorrhage situation. How much would I give? So usually you can use this long formula here. I tend to just be simple. 1 mil per kg will increase my PCV by 1%. And so a packed red blood cells, 2 mils per kg will increase by 1% with whole blood. I just tend to use that formula. So if I usually in most cases I'm around 15 or so, and I want a 10, a 5 to 10% raise, so I'm gonna give about 5 to 10 mils per kg. If I usually am not going to go above 25%. I don't want to go above 25%. Like I don't need to give them that much blood, but you're usually giving somewhere around 10 mils per kg in most cases. How quickly would you give it? So what I tend to do is I know that if I let that blood sit out for more than 4 hours, there's a greater chance there's going to be, it's going to get contaminated, or I'm going to develop a problem with that blood from it sitting out too long. Big one being, bacterial contamination. So I tend to try to give it over the longest period that I feel is safe. So if I'm giving 100 mils, I'll just say 100 divided by 4, 25 mils an hour, and that's how long I'll give it over. I tend not to ramp up. I tend not to do any of that stuff, just because it just makes everything very much more complicated. I like to make things simple. So I'm going to give it at 25, if I give it 200 mils, I'm going to give it at 50 mils an hour, because that's how long it can
Also,
sit out.
in my experience of just giving the transfusions and monitoring them, I have never had like a reaction based off of ramping up or just going like what you just said, that 25 mils over, the 4 hours to get the 100.
Yeah.
It's like you're going to see the same reactions within the same amount of time, at least in my experience of monitoring. So I'm all for just like starting that, like nursing standpoint to all the doctors here. I'm all for like the starting it at what you want it to be at and not the increasing. I think
Yeah,
it works for everyone.
it makes life much, much easier. And you are monitoring them more closely initially, and the argument would be like, well, the more you give, if you're going to have acute hemolytic transfusion reaction, right, and that's the one reaction we're going to focus on. But if you're going to have that, the more blood you give, the worse it's going to be. But, and that's true, but, most of the time, if you're monitoring them fairly, if you're doing a more frequent monitoring at the beginning, you'll catch it, and then you should be able to stop it. And most of the time, you have more allergic reactions, things like that are treatable with Benadryl and things like that. So yes, that's how I like to do it. Do be careful, because sometimes if you slow it down, it ends up sitting out for more than 4 hours. So sometimes what you have to do is take some of it out, put it in the fridge, and then once you get to the next point, give it. But if you're having they're having some vomiting or fever, and you decide you want to slow the blood down a little bit to stop that reaction, which is usually due to something like the white blood cells in the blood, then you don't want to sit out too long. What if you crack open a unit of blood and you put it in the fridge? How long is it good for in the fridge? 24 hours.
36 hours.
Yeah, 24. So it's good for a full day. Now, let's just say the owner has no money and that blood's been in there for 36 hours. Would you use it? I would tell the owner. Yeah, I would tell the owner, hey, you don't have any money, and I have a unit of blood there. Theoretically, I can't use it past 24 hours, but it doesn't mean that at 26 hours it magically is contaminated. It's just a greater chance. It's like milk. They have an expiration date, but my grandmother used to always tell me, you can still drink this milk, right? So you can still use that blood, but you have an increased risk with it. But if the dog's going to die without it, and it might die with it, I'd go with the might die versus the is going to die without it, right? And then there's this theory of volume limited resuscitation, where you try to, like, if you have like a dog with bleeding and you want to restore the volume with crystalloids, you want to be careful not to give them too much blood and increase the blood pressure up too high, because that just will cause dislodge your clot that's formed, and you might get more bleeding. So the basis between volume limited resuscitation is to just be careful with your resuscitation in a bleeding dog, because that clot formation is key, and you don't want to overdo it and then dislodge that clot.
That's a good point.
Yeah.
That's a good point.
Okay, so let's talk a little bit about, we're going to talk about blood types in the dog, and then we can come back and do some blood types in the cat and stuff later, and we'll touch on it a little bit. But you have so many blood types in the dog, and I just listed a few of them here. There's actually more than this. There's something called the Dow factor. There's new things we're finding all the time. But the one that tends to be the most important is this DEA 1.1. That's the one that tends to cause the acute hemolytic transfusion reactions that we're all afraid of. When we see like fevers, when we see like hives and vomiting, those are all type 1 allergic reactions. The acute hemolytic reactions is a type 2 reaction, where you have antibody formation and the antibodies attacking the red cell and destroying it. Type 1 allergic reactions are due to histamine release from mast cells, are usually associated with IgE, and they're usually associated with white blood cells, not so much the red cells that are in the blood product that you're giving. We can also see febrile non-hemolytic transfusion reactions, and those can cause problems. There can be blood contamination. You can have citrate toxicity that can cause hypocalcemia. You can have things like FIV and stuff transmitted from one animal to the other. Those are all considered, blood transfusion reactions. But the one I want to focus on is the one that we all worry about. And we're like, can we give this dog negative blood? Can we give it positive blood? What can we give, right? And so on the surface of the red blood cell is something called a dog erythrocyte antigen, or DEA, right? Dog erythrocyte antigen. And you have not just one antigen on the surface of that cell, but you can see here, I've listed about 8 or 9 of them that you can, about 8 or 7, 8 of them that you can potentially have on the surface. And this, again, is not a complete list. But the one that we test for when we say a dog is negative or positive is we're saying it's DEA 1.1 negative, or we're saying it's DEA 1.1 positive, meaning DEA 1.1, it does not have the antigen if it's negative, and it does have the antigen if it's positive. So I want to, before I go back into this, I want to show this slide here. So this is what's showing this dog has several antigens on the surface of its red blood cell. It has the 1.1, which is a star. It has a DEA4, which is this yellow circle. And it has a DEA7, which is this yellow triangle. And the one that, again, causes the acute hemolytic transfusion reaction that can be really, really bad is this 1.1 antigen. And the way that that antigen is going to cause an issue is antibodies are going to recognize this antigen. They're going to attach to it. And then that's going to cause things like red cell lysis through complement activation and other processes within the body where it destroys that red blood cell because that antibody recognized it, right? If you have a dog with IMHA or immune-mediated hemolytic anemia, its body did not, should have recognized that that protein is its own, and it should not produce antibodies against it, but it's producing antibodies against it and causing destruction of that red cell. Now, dogs don't have naturally occurring antibodies to the DEA 1.1 antigen. So that's why if I have a dog that is DEA positive, if I have a DEA negative dog and I want to give it positive blood, there's no natural antibodies in there that would cause it to recognize that positive antigen I'm giving it and cause destruction of that donor's red cells, right? So the recipient gets a positive, it's a negative donor. I mean, it's a negative recipient and it gets positive donor blood. It doesn't recognize that positive donor blood right away. It takes time for it to do that. So what's that process that occurs that causes that dog to start forming antibodies against that donor's positive blood or against that donor's blood that has the DEA 1.1 antigen on it? Well, first, a B cell might look at that antigen, and that B cell has to have antibodies specific for that antigen, not just any B cell. It has to be a B cell that has receptors on it that recognize that DEA 1.1 antigen is one B cell in that body, right? It's crazy. It's just a few of them, right? And so they recognize it, and then when they recognize it, they can start performing some antibodies, but they don't form a lot. What really has to happen is a T helper cell has to come across an antigen presenting cell like a macrophage that also has consumed this 1.1 antigen and starts presenting it on this MHC molecule. And then it recognizes it, it activates the T helper cell. The T helper cell then finds the B cell that's also presenting this antigen and activates that B cell. And now you can form lots of antibodies. So how long, the reason why I showed this is I don't need you guys to memorize all this, but how long do you think this process takes for, if I gave this recipient dog, this donor's red cell here, that has that 1.1 antigen that dog does not normally have. So it's going to have a B cell that's going to recognize it. It's going to have a T helper cell that's going to recognize it. It's going to present it. It's going to activate that B cell. How long do you think that process takes for that dog to start forming antibodies against that donor's blood?
I have to say my biochem background, this is great. So
it's gonna take about,
it's gonna be a long time.
Yeah, it's gonna be like 5 to 7 days. Yeah. So that's why when you guys, you'll have a dog that comes in and the dog is DEA 1.1 negative, and all we have is positive blood. I'll say, give the positive blood, right? Because I know that dogs don't have naturally occurring autoantibodies. So it can get a positive donor's blood and it's not going to have antibodies that are going to attack that blood. So it'll be fine. There's certain situations where that may not be true, and we'll talk about that in a second. But in general, a negative dog can get positive blood and it won't have a problem. But after 5 to 7 days, it's going to have a problem, right? Because it's going to start forming antibodies, and maybe even as long as 3 days. So at day 1, day 2, even day 3, I'll give that negative dog positive blood all day long if I think it needs it. I'm almost done. I'll give that negative dog positive blood all day long if I think it needs it. But after that, I know it's starting to form antibodies, and I'm not going to, give it, any longer because it's going to be more likely to react to it. The other reason, even if it's a negative dog and I'm giving it negative blood, right? I'm still going to cross match after 3 to 5 days because now these guys, 1.2, 3, 4, 5, 6, 7, 8, they all become more important and that now it has been exposed to those other antigens. It's starting to form antibodies against those other antigens as well too. And now that I have antibodies against them, they might start to cause some problems, especially ones like 4 and 7. So as you as a dog has been exposed to another dog's blood and it's more likely to have antibodies, the concept of cross-matching is going to become more and more important. If a dog was negative for every single antigen, it would be the universal donor. If a dog was positive for every single antigen that dogs have, it would be the universal recipient. So, but we don't know. We don't test for every single antigen. So we don't know which dogs are universal donors, and we don't know which dogs are universal recipients. Does that make sense?
Yes.
Yes.
Okay, so we need to cross match. If they've been given a blood transfusion before, so prior transfusion or prior pregnancy. And that's why sometimes in these dogs, and if it's a breeding dog, that's going to be important to know, because if it's a female and it had a puppy, where the dad was, say the female is a negative, DA1.1 negative, the mother, and the father was a positive dog, and so some of those puppies in there have positive blood, that mother has now been exposed to their blood and she'll start to form autoantibodies. So pregnancy would be another reason you need to cross match. And then major cross match and minor cross match, that's just, most of the time we're doing major cross matches. We never do a minor cross match. A major cross match is where you're looking for antibodies in the recipient's blood against the donor's red blood cells. A minor cross match is where you're looking for antibodies in the donor's blood against the recipient's red blood cells. We rarely do a minor cross match. We almost always do a major cross match, and we can look in more of that later on if you guys want. So this is the test that we used to have a system where you'd wash the red blood cells and look for agglutination. That test was very complicated. We tend to use this test here now. And what it does is if they all settle at the bottom, it didn't react. But if they start to settle at the top, they did react. Occasionally, I'll see something like this. And, I'll test several different units. And I see one like this. Okay, I'm not going to use that one. But the other two look like this. And I'm like, I'm going to use, the one that didn't go up to the top as much. Is real subjective. But this is probably the easiest test we have right now that looks for, evidence of a reaction or not. And it's a pretty decent test to use. We won't talk about collecting blood because that's just a whole other process. In cats, you have A, B, and you have AB. Cats do have preformed antibodies, so you have to, check the blood type on a cat, and you can only give A cat A blood and B cat B blood. If you give a cat B blood, it will react to it. It may not die, but it will react. If you give a B cat A blood, it will react and die. It's really, really bad. Luckily, most of our cats are type A, and most of the blood we get is type A. And then we talked about all these different transfusion reactions. We'll hold off on that. Steroids, giving steroids and antihistamines before, it's not bad to do. It's not necessarily, studies haven't shown it makes a difference, but, I don't think it's necessarily a bad thing, and it's okay to do it. Monitoring for transfusion reactions, we talked about that. Look for hives. If you see a dog that has acute hemolysis, there's really not much you can do other than stop the transfusion reaction. And then if they have like shock and stuff like that, you give fluids and try to resuscitate them. If it's an allergic reaction like hives, things like that, for sure I would give Benadryl, maybe steroids. But how I'm going to treat it depends on what I think it is. If it's a acute hemolytic transfusion reaction, it's not a histamine thing. It's not a mast cell degranulation. That's more of a type 2 reaction where, they have antibodies that are lysing those cells. You just need to stop the transfusion so those cells aren't in there, and that will stop the immune system. And then if they have any shock or anything like that, treat that. If it's a allergic reaction, due to white blood cells, things like that, then you give histamines, antihistamines, and steroids and all those types of things. Okay. I think I've said enough. And like I told Joe the last time, I don't expect that you guys are going to know everything about red blood cells and transfusions reactions tonight. This is things that we're going to do over and over and over and over again. And as we do it more and more, you will get, it'll start to sink in. But I think we're good for tonight.
Okay.
Can I ask a
I
quick question?
Yeah.
Go
No,
ahead,
you
Justin.
first. You first, Joe. Get
All
it,
right.
Joe.
My question was for cat transfusions. Did you say that A to B is worse, or is B to A worse?
Giving a B cat A blood is worse than giving an A cat B blood. Now, none of them are good.
Right.
None of them are good. And then most of the cats we have in the US are A, so A for American. Most of the cats in Europe are a good number of them, especially the purebreds are B, so B for British. And again, the British really don't like the Americans. They really don't want their blood. But the Americans, sometimes they'll accept the British. They'll be okay, but they don't like it.
Good way to think of that.
That's
All
how I
right,
remember it.
I got one for you. So you remember that? You remember that? I got more than one. I have a few written down, but I know I'm not taking everyone's time. So you remember that GDV Dane that came in? It was smooth. McDougal came in. Anderson kicked ass. Joe chokered. I know everyone here remembers that case.
Yeah, yeah.
So when McDougal was in surgery, she was like, "I need an immediate platelet estimate right now, like as fast as you can get it done." At that time, could we have used the morphology of the CBC to get a more stat reading? Because we did do like a staining, a slide, a staining sheet, like those results. The patient was already euthanized pretty much by the time those results came through. So like, is the morphology okay to use in that type of instance? I know it's not really, it's related to what we're talking about, but not really. You know what I mean?
Yeah, no, I got you. So I would say the morphology is okay to use. Now, some people don't like the morphology because it's going to give you less than 50,000, it's going to give you 50 to 100, or it's going to give you greater than 100. If you talk to a clinical pathologist, they prefer that method because they say it's fake news. In other words, they say when you do these platelet counts and you get 10,000, 20,000, that's essentially the same number. If five people were to do
I
that,
understand that. I
yeah,
get that. I get
yeah.
what you're
So,
saying.
so, so I would say, not everybody's going to agree with me, but yes, the blood morphology to me is a better way. It's not going to give me an actual number that tells me where it is, but I also know that we really don't have a good way to get an actual number. And so it gives me a
Okay.
rough idea of where I'm at. I'm less than 50. Ooh, this bleeding might be due to these little platelets. I'm 50 to 100. Well, if I'm at surgery, then it might be due to these little platelets. It's greater than 100. It shouldn't be bleeding at all, even with surgery.
All right, Dr. Walker, I got another one for you.
Okay.
Okay. All right. So remember how you showed the image of the x-ray, the widening mediastinum, right?
Uh-huh.
Bleeding into it. I remember you teaching me that some patients have like a fenestrated mediastinum. For those patients, would you see would there be like a slower rate of widening, or would there be something else you would see in the image if there wasn't any widening? Does that make sense? I couldn't get it
No, it makes
down.
100% sense. I don't have a good answer for you. So usually in cats and dogs, the mediastinum is fenestrated, and so stuff on the right side can go to the left side, and stuff on the left side can go to the right side. Versus in horses, they don't have a fenestrated mediastinum, so a lot of times stuff will get stuck on one side and it'll stay on one side. I think humans are the same way. Now, why does it not go out the mediastinum into the flow space? I don't have a good answer for you on that
I was
one.
like, I don't know.
But
That's why I'm asking.
yeah,
Okay.
yeah, that's a good
Okay.
question, but I don't have a good answer for you.
Okay. This is my last one. I promise.
Okay,
I
okay.
am very surprised that this patient that we were being taught about did not have any petechial hemorrhaging on any of the gums or just anywhere from what you were showing, right?
Mhm.
Is there a time frame of ingestion from the patient to presentation that you would see that, or you could overlook it? Like you could be like, oh, it actually doesn't have petechial hemorrhaging. It's not that, but 4 hours later, it does have it. Like, is there a time frame that we should know, or you know what
I
I
don't.
mean? Like, I'm
Yeah,
surprised this
hard to
patient
say.
doesn't
So I
have
don't.
it.
Yeah, I, I don't have a good answer for you on that one. Now, this case is just a case I just made up. So it in a real life, it could have it. It could not have it. How long that takes to develop, I don't know. So usually, like ecchymotic changes are usually associated with clotting factor disruption. So they get the more like bruising, and more likely, I would say the answer to your question, in my opinion, is that not just my thinking about it, is that the more trauma they have, the more likely to have those little excoriations or those little, ecchymotic changes. low platelets is more associated with petechia. And, usually you're going to see those when they're getting below 50,000. And
Okay.
how quickly they take to develop, I don't really know, but, they definitely do develop in your ITP patients, stuff like that. So, again, I can't give you an exact number of how much, but, as you start to, have clotting factor prolongation, you're going to see ecchymotic changes. And as you start to get lower and lower platelets, you can see petechia, but how long it takes, I don't know. But definitely the more trauma they have, the more likely you are to see those things.
Okay, wicked. Thank you.
For these rodenticide cases, like how low does the platelets usually get? Like it's not going to be ITP where they're like 0.
So if they have a low platelet, the main thing that they have is clotting factor. So you have primary hemostasis and secondary hemostasis, right? So primary your platelets, secondary your clotting factors. So the main thing that they have is secondary hemostasis problems. Now, as they're bleeding and bleeding and bleeding, they can get loss of platelets that way, and then they start to get petechia as well. But they're primarily clotting factor deficiency, not platelet deficiency. Although if they bleed enough, they can have primary hemostasis issues as well, in addition to their secondary hemostasis problem. Does that answer your question?
Yeah, I think so. Thank you.
Cool. Well, I'll see you. Whoever's there tomorrow, I'll see you tomorrow. And I appreciate you guys coming in.
Yeah, thank you.
Yep, it was great. I'll see you guys later.
Sounds good. Bye.